My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Brigham and Women's Cancer Center. So we're seeing much greater use of neoadjuvant chemotherapy today in our breast cancer patients. And this has been largely driven by the recognition of the high rates of response to neoadjuvant chemotherapy, particularly in women with HER2 positive or triple negative breast cancer. And in working with our multidisciplinary teams, we are really identifying the women who we think will truly benefit from the neoadjuvant chemotherapy approach. In our setting, when we have a patient who is considering neoadjuvant chemotherapy or in whom we are considering neoadjuvant chemotherapy, as surgeons, we really think about how can we optimize the local regional outcomes following that neoadjuvant chemotherapy. And the one way that has become increasingly clear to us is that using neoadjuvant chemotherapy provides us with the opportunity to downstage the axillary lymph nodes and potentially avoid axillary lymph node dissection in women who may have started with node-positive disease. So in our preoperative evaluations, we do recommend ultrasound of the axilla prior to initiating neoadjuvant chemotherapy. We recommend this for women with both clinically node-negative axilla as well as those with clinically node-positive axilla. We do biopsy any abnormal appearing nodes, either with ultrasound-guided FNA or ultrasound-guided core biopsy. And we do ask our radiologist to place a clip in the biopsied node. In the event that it is positive, we want to be sure that we can localize and remove that node at the time of surgery. So again, when patients then go on to receive their neoadjuvant chemotherapy, we reevaluate them at the completion of treatment. And if they've had a response in the axilla, if they've converted from clinical N1, for example, to clinical N0 disease, then we do offer them the opportunity to undergo sentinel lymph node mapping and biopsy. The feasibility of sentinel lymph node mapping and biopsy in this setting has been studied now in several large prospective trials, demonstrating the false negative rate of this procedure, demonstrating the importance of surgical technique when applying this procedure in this population of patients. And we now have trials that are reporting very good rates of local regional control following sentinel lymph node mapping and biopsy in patients who actually have a pathologic nodal complete response and avoiding lymph node dissection. So the techniques for performing the sentinel lymph node procedure in this setting are varied. There are some commonalities that different groups support. One is that we should always use dual tracer when doing a sentinel lymph node procedure after neoadjuvant chemotherapy in someone who started out with clinical N1 disease. Some groups mandate removal of at least 3 sentinel nodes and confirmation that all of those nodes are negative on pathology to omit axillary node dissection. Other groups routinely localize the clipped node and mandate removal of the clipped node as well as 2 other sentinel nodes, again with confirmation that all 3 are negative on pathology to avoid lymph node dissection. The best technique for doing this has not been tested, again, prospectively in any single arm or randomized setting, but all groups have reported excellent rates with the technique that works best for them. The importance, again, of identifying that residual disease after neoadjuvant chemotherapy is twofold. One, we certainly don't want to leave any disease behind in the axilla, but we also know that adjuvant systemic therapy decisions are also made based on the finding of residual disease in the nodal basin. So we really, as surgeons, we really want to be as accurate as we can in performing the sentinel node procedure in this setting and ensuring that if we are omitting axillary node dissection, that we're confident that the technique that we have chosen has a low false negative rate associated with it. As I mentioned, there were data just presented at the San Antonio Breast Cancer Conference a month ago now from both the Memorial Group as well as the Milan Group, showing that they have applied this technique to patients who start out with clinical N1 disease, converted to clinical node negative, underwent sentinel lymph node mapping and biopsy with the procedures of choice at those institutions. And many women were able to omit a lymph node dissection having achieved a nodal PCR. And with follow-up time in the 2 to 3 year range, there are very low rates of isolated local regional recurrence. So it does appear that this technique can be safely applied in these patients. And again, the ultimate goal is to really minimize the morbidity of the lymph node procedure. And by being able to extend sentinel lymph node biopsy to women who start out clinical N1 and have a good response to neoadjuvant chemotherapy, this really opens up that opportunity for many more of our patients.